first thing is to recognize that there are multiple different forms of urinary incontinence, and both men and women can suffer from incontinence. Specifically, when we talk about women, we talk about two main types of incontinence. One of them is called stress incontinence. It comes from a relaxation of the pelvic muscles. Typically, stress incontinence is your classic when I cough, when I laugh, when I sneeze, when I do jumping jacks, when I jump on a trampoline type thing. Typically, stress incontinence is encountered in women who've had children, typically with vaginal deliveries. Women who have all their children via cesarean section have a significant reduced risk for stress incontinence. The other type of incontinence that can be suffered by both men and women is a type of incontinence called urge incontinence. Urge incontinence is a little bit different. Urge incontinence is when you get home from the grocery store, you're fumbling through your pocket to find the keys to get into the house, and all of a sudden you feel like you have to go. And you can't find the key quick enough, and it typically has your entire bladder will empty. And so urge type incontinence oftentimes is a little bit more difficult to deal with because it's harder to deal with that with just a pad. There's not really a pad made that will absorb all the urine that your bladder is going to produce if your bladder is going to empty completely. Urge type incontinence is typically and almost always associated with having an increase in urinary frequency, sometimes waking up at night to urinate, and is almost always started by an urge to urinate without time to make it to the bathroom. Stress incontinence, you never know what's happening until it happens, and it's typically not associated with an urge. For a woman who is having stress incontinence, there are several different good therapies for stress incontinence, but almost all of them involve either pelvic floor retraining, building those muscles back up again that have gotten weakened, or some type of a surgical intervention to actually alleviate the incontinence. The biggest concern that I have, or one of the biggest concerns that I have, is that women, for some reason, tend to think that leaking urine is a natural process of aging for a woman who's had babies. And while it's very common, it's not considered a natural process, and it's not something that someone has to just kind of accept that this is just the way they're going to be. And the women that are interested in pursuing biofeedback or working with a physical therapist for pelvic floor retraining, they can expect somewhere between a 30 and 35% chance that they would be able to get themselves to dry. It takes a little bit of a longer time to do this, and it takes a real commitment from the patient. If they've tried this already and if they've decided it's not working effectively enough, then there are several different surgical options to help fix the incontinence. The surgical options can have dry rates of as high as 85%. Typically, most of the surgeries are outpatient surgeries. Sometimes they can take as little as 15 or 20 minutes, and the recovery can be no more than 2 to 3 weeks at the most, with the majority of the recovery not being associated with having pain, but the majority of the recovery being associated with just having to take it a little bit easy in order to make sure nothing affects the surgery that was done to help with the incontinence. Urge incontinence, on the other hand, is typically a medically managed condition where we actually put patients on medications to calm the bladder down. As a medically managed condition, though, there are now 2 FDA-approved devices for urinary urgency and frequency. One of them is called an InterStim. It's a surgically implantable device that acts kind of like a pacemaker for the bladder. That's for the patient who either the medicine doesn't work or they're having side effects from the medications and they can't take the medications. The other one is something called Urgent PC, which is actually a stimulation of the posterior tibial nerve down around the ankle. That nerve actually plugs into the spinal cord around the same place of the nerve that stimulates the bladder. So you can actually stimulate the nerve down around the ankle in the office without permanently implanting anything, and it can actually help with urinary urgency and frequency that way as well. Really, when you're treating stress-type incontinence, what you're looking to do is to provide support for the urethra. One of the ways it's become much more popular recently, because it's very easy to do and because it's got very good results, is actually utilizing mesh, so a synthetic mesh, to actually provide the support for the urethra. People need to be informed what their options are, though, because there are several different options for material that can be used to provide that support underneath the urethra. They've gone so far as to put out some biologic material to provide the support for the sling. The main difference between the biologic material and the mesh material is that the biologic material with time will start to get softer and weaker, and so typically there's a higher incidence of return of incontinence using the biologic material. The mesh material, once it's put in, it doesn't change. The risk that you take by using the mesh is that there is a very low incidence of complications, but those complications can be significant. Unfortunately, whenever we do surgery on someone, there's always a risk and there's always a benefit. And so ultimately what it comes down to is we all have to have a discussion and say, Do the risks outweigh the benefit, or do the benefit outweigh the risks? And if the benefit outweighs the risk, then it makes sense to move forward.